visualize, not the pedicle, but the
Intervertebral foramen.
intervertebral foramen. Why? What runs through the intervertebral foramen?
The core,
Van.
yeah,
Van.
veins, arteries, and nerves.
Okay.
The bundle.
So in order to see the IVFs, they're not at right angles to where you are. They're at 45 degrees. So we're going to make our patient stand at 45 degrees, and they need a tube tilt. So the challenge with oblique views is tube tilts. All right. So that's what we want to cover in addition to flexion and extension. Whoever's closest to the door, lights please. All right, so vein, artery, our IVFs, vein, artery, and nerve, don't make it any more complicated than that, all right? And the thinking is, let's see how it works relationally for you. If the disc is injured and narrowed, it can cause encroachment to the IVF. So can the uncinate processes. Where are the uncinate processes?
On the top.
The vertebral body.
Oh.
Tops of the vertebral body.
Okay.
They're the containment processes for this disc space. If I have injury or degenerative changes to the uncinate processes and or the disc, you can have compromise to the IVF. All right? That's why we want to see them. They usually they can't have, so if you have insult to the uncinate processes, they can cause insult to the IVF. It usually is disc narrows, and as a result of that, the IVF becomes narrowed because there's a combination of disc disease, insult, and uncinate process change. All right? But they can also happen in isolation. So now this is the patient who has what? Pain down the arm, radiating pain of some kind. All right? But everything is case dependent, meaning just because I have severe degenerative disc disease, I may not have IVF encroachment or narrowing. But these are the views that will show us the IVFs the best. Okay? We're going to go through the same routine. Okay, and this is a nice 3, 4, 5, 6, 7 view cervical spine region. This is posterior tubercle. This is what collimation does for you. All right, and I'm always emphasizing to you, this is about the size of the paper clip or the 8.5 by 11 inch piece of paper. But you want to be inside that. The spine's in the middle. The more we concentrate the X-ray energy by bringing this edge or that line that you get and make it smaller, the more clear for your purposes will the X-ray be. Is that important? Yes. The more you can get the interface between the subcutaneous tissue, the muscle, the bone, and the parts of the bone, the more information you're going to get. Okay? And we get that predominantly by concentrating the X-ray energy and moving the rectangle in from the side. The spine's in the middle. That's why that works so well. All right? Okay, let's talk about location. So I said to you, the vertebral artery runs through the foramen intertransversarii, so we need to know where those are. So if I go back, okay, you have to hallucinate just a little bit. There's a U-shaped structure. That's the transverse process. That's where the intervertebral artery or the vertebral artery runs. Diagrammatically, the carotid is anterior to the foramen intertransversarii. Yes?
Yes.
Okay, and the big teaching point is this rarely calcifies, this commonly calcifies, especially right here where it bifurcates. This is anterior to the spine. That's an important anatomic point. The more this artery calcifies, it not only has calcification within it, but it slows down the blood flow, right? Okay? And the minute you turn your patient, he says, when you turn my head, you say, look straight ahead. I can't, I'm doing this. But the minute I do that, I start getting dizzy. What does that tell you?
Cut it off.
There's compromise to the carotid arteries and or the vertebral artery, okay? And especially on a clinical examination, when they extend their head and they start getting vertigo symptoms, all right, that's your first clinical clue that there's something wrong, especially in the elderly, with calcification either here, here, and less likely in the vertebral artery, all right? But it's also understanding that this is anatomically in the transverse process region, this is in the anterior soft tissues, because when you look at your x-ray, you have to know where the two regions are. Now, why do you think I'm telling you that? Do I see it a lot, not see it, or what's the other only option? I see it a lot, okay? You're gonna be the one that treats. Okay, so let's take it to the next step. If there's calcification here, and the patient says, I'm getting dizzy when I turn my head, is that when somebody you want to say, please lay here and go,
No,
why not?
it's gonna make it worse.
Okay, but what's the worst scenario of worse?
Potential.
Dissection.
Embolism.
Stroke, dissection, okay, this doesn't do anything, but that force can cause some of that calcific flaking to dislodge and then migrate superiorly. Okay, the chiropractor gets blamed because you caused the stroke. No, you didn't cause the stroke, they were pre-existing. They have comorbidities. So the calcification that you see on the x-ray anterior to the vertebral bodies tells you something, especially when the patient says, I get dizzy when you turn my head. All those things, plaques, okay? But you now just put the clinical picture and the radiographic film together, and that's what it means to you, and you're making a clinical decision. First time we got together, I said, you want to find calcifications in the abdomen or anywhere else, what diagnostic tool do we use? X-ray? No, we said in addition to X-ray, there's all these other choices. X-ray was one of them, right? If I want to chase gallstones, what diagnostic tool did we emphasize?
Is it MRI?
Not MRI, not CT. Okay, we can go all the way down the list. Play eeny, meeny, miny, moe, right? I emphasized what? Diagnostic ultrasound. First lecture. Okay, when I say teaching points, you need to pay attention. Diagnostic ultrasound. And that same modality we're going to use for calcification in the carotids and the vertebral artery. So when you send your patient who has dizziness and you find this on your x-ray, especially if it's bilateral, they're going to do a diagnostic ultrasound of the carotids and the vertebral artery. That's the application to what we're talking about and learning about. Now, it happens in what, 13-year-old males and females, or 63-year-old males and females?
63-year-old.
You're gonna have a few of those, right? Okay, you have to be sensitive to that. You're not just taking the x-ray. Well, some chiros take the x-rays, they want the reimbursement. No, that's the tool that helps you manage your patient. Okay, and I'm just going off on it because it happens to be a nice example. Anatomic location, anatomic location. Learning things just to pass the national boards is bullshit. You're gonna practice, and when you practice, you're making decisions that affect treatment and clinical outcomes, yes?
Yes.
Okay. We showed you this before. I think this is where we're sort of where we left off. Okay, so what was the abnormality here?
No posterior arch.
Good. No posterior arch is the clinical finding. What's the clinical significance?
No protection.
No protection. At risk. Okay. Their canal in this area is at risk. Okay, and then we said there were certain things we needed to consider. What was going on here? This one?
The vertebral bodies are together.
Okay, so if you're not seeing it, you need to take a look at it and say, okay, why is C4, that's a normal rectangle, this one is not normal. That's the observation. How you get there, we'll talk about when we do our search pattern. So this motor unit 5-6 is different than 3-4, yes? Okay, and the application is, look at this interspinous space. This one is different. So that's why we will, when we talk about the flexion extension view today, that will help us, all right? And then last but not least, what's happened to this patient? for you is vertebral body. Now you say, how do we know that? Either I remember it from last time, but this is a metal density. You shouldn't have a metal density in your cervical spine unless it's been surgically introduced. Okay? Now, even though it's metal, this is a normal disc height. What's happened here?
It's more anterior.
More anterior? Is it the same height as this?
No.
No. So we're trying to get you to understand you are looking at an x-ray and you're making observations, okay? And we're making observations at each level because it's different here than it is here. It's different here, and it's got this metal plate inside of it, all right? Now, you think this neck has a normal range of motion like someone who doesn't have?
No.
Oh, it's gonna be different. How do we evaluate it? We're gonna do this flexion view, and then we're gonna do the extension. So there's always theory, application, theory, application. So you can pass the written exam with flying colors, but if you don't know what this information means or how to analyze it and make good clinical decisions, we sort of have a misbalance between theoretical information and practical. All right, let's get to obliques. Okay. Come on up. Okay, just stand, let me stand you, turn you just like so. She's at 45 degrees, yes?
Mhm.
Which shoulder is closest to this?
The right
The right,
side.
which marker goes here?
Right.
So it says anterior obliques. So anterior obliques, we can choose how we do anterior obliques. So we've got her position to do an anterior oblique view. The teaching point is, put a big mark star beside this. It goes 10 to 15 degrees, should be just 15, 10 to 15, so it's consistent with everything else we do. 10 to 15 degrees, which way?
Cauda.
I know Caudate, what does that mean?
The head.
Caudate?
Called equina tail.
Oh, okay.
Caudate equina, tail, down, okay? And you want to put another mark, it's the only one that goes down. Which way did AP lower cervical go? Up. If you're stuck on an exam, chances are it's up. This one happens to be down, and it's the only one that's down. So when we do anterior obliques, we tilt our tube down, same place, thyroid cartilage, okay? So we might as well get right into the light, so we can all see you, the star, okay? So a right marker goes here, okay? I'm still aiming at the thyroid cartilage. The projector is at 72 inches. Not 40, but 72. So once I do my AP open mouth, AP lower cervical, everything else is at 72. Okay?
Mhm.
Now we position this central radial of the thyroid cartilage just like we did on the lateral view.
Mhm.
All right? We've set up everything else the same way. All right? And now we're ready to push the button. So everything else in terms of steps stays the same. But the idea is we're wanting to see the IVF, right?
Mhm.
The question is which one? And that's where now it becomes a lot more challenging. Now I don't know which way works best for you. I'll show you a couple different ways. The first one is on a right anterior oblique view, I will see the right IVF. If you want to write that down, or I'll write it down on the board so we have it correct. How am I going to write it? Cervical, RAO equals. Cervical, LAO equals. And then we're going to have a C, cervical, left posterior oblique, C, right posterior oblique. So the first one is you just memorize it. Okay, the second way is, come and stand here again for me, patient, please. Your name is Jenny, okay? I'm going to use her elbows as the IVFs, okay? So if you're standing like this, I want you to just put your arms like this. Okay? One step forward. Okay, and I want you just to move this arm a little bit further back onto your hip. Okay, I want to create it, no, just let me relax, just, okay. The X-ray beam's coming from the projector. It hits this elbow. It can go through this elbow, but is it going to be show you a clear opening of her foramen that we've just created?
No.
Okay, but on the right side, the X-ray beam can go right through and leave the edge that I created with my hand on the X-ray film. So on a right anterior oblique view, which IVF do we see the best?
The right side.
Okay. That's factually correct. And if that's a true statement, what happens when I do this? Let's turn and do the opposite side. It's going to be the left side. Okay?
Mhm.
So it's also factually correct. Now, every office does it differently. Okay? The advantage of this way, the anterior part is closest to the film. There should be less magnification. You don't even know what that is, but there's less of a magnification effect. All right? Some people will argue, well, I want the spine closest to the capturing device. So we can do a posterior oblique view. If I stand you this way, no, just relax your arms. Which shoulder is closest to the film?
The left
The
shoulder.
left. That's the marker. We always mark the side that's down. Okay?
Mhm.
All right, now put your hands the same way we had before, and I'm just going to exaggerate. Okay? So I'm going to turn you ever so slightly. I'm going to hide this one. Just bring this arm back a little bit. Good. On a left anterior oblique view, and if you bring this back, okay, which IVF is clearest to you?
The right.
Okay. Left posterior oblique gives us the right. Okay, and if that's factually accurate, if I do the opposite side, I should have the left.
Mhm.
Now the difference with, if I change the slide, if on anterior obliques I tilt the tube down, what do you think I'm going to do on posterior obliques?
Tilt it up.
Tilt it up 10 to 15 degrees, cephalad up towards the head. Does that make sense?
Mhm.
Okay? Jenny, thank you. And I'll give you a chance to write this down. So it doesn't matter whether you memorize it and get it, or you follow the model that I just did. Okay? And just for now, just put that, just write that down. We'll apply it either later on today. I want to get you off on the right foot with this. Okay? So anterior obliques, your choice. That just happens to be from the top down. And the key to it is the 45 degrees. And that's pretty easy to do because you just sort of, okay, divvy between right angles. All right? It's easy to position the lab is the point. Okay. This stays the same, thyroid cartilage. All right? On anterior obliques, we're pointing down towards the tailbone, coccyx, caudate, equina. All right. Posterior obliques. 10 to 15 degrees, cephalad. Everything else stays the same. All right? Can you look straight ahead? No rotation of the head and no lateral flexion of the head. And the image that we get looks like this. So these black holes are the IVF where the van comes out of. Okay? Now we can have, this is the marker, we mark the side that was closest to the film. But at the office, we're going to follow that convention, but there's offices out there that don't follow the convention. Okay? Now, if you get the x-rays from the other office, don't try to guess at how they did it. You're going to have to physically call them and say, was the patient's front to there, the capturing device or the film, or was their back to it? That satisfies all of that misinformation and possible wrong diagnosis, if you will. All right? But I know for sure if I do a right anterior oblique view, I will see which IVF? Right.
side.
Okay, that's all you need to know. Now, it's your job. Who's doing the RAD report? The CA or you?
Us.
Okay? If you get this part of it incorrect and it's the right IVF when it should have been the left, that's all on you because you're signing the paper. Okay?
Mhm.
Now, with the computer setups and the digital x-rays, they can put this R on after the fact. It's a computer, just put it on there. Is it possible that your CA does it incorrectly?
Yep.
Whose office is it?
Yours.
It's all on you. Now you may have to retrain them. You may have to tell them, okay, you're doing this incorrectly. Okay? In the state of Florida, they have to go through a training program, write an exam, and then they're deemed to be able to take x-rays. X-ray isn't about passing a written exam. X-ray is about hands-on information.
Mhm.
So that's how easily this can go wrong. Okay? Now, just like I said the other day, if you call the office and say, can I talk to so-and-so about these x-rays? Well, that person isn't here. Okay, won't be back until Friday. Let's make it that. Okay, what does that do to you clinically?
No good, you're home.
No good, you have to wait, you have to withhold, you're not able to treat the patient the way you normally would because you don't have the right information, okay? You're expecting, it says right, pain down the right arm, no, it's not the pain down the right arm, it's actually the right arm, the left arm. Well, who's right? Were they mismarked? What's the true status of the affairs here, okay? You will follow, we follow the convention, we're gonna mark the side that's closest to the film. What happens out there, we have no idea because we don't know which school they went to, what kind of training they got, but that's how mistakes happen. Okay?
Mhm.
All right. Just examples of IVFs, no markers, that's a problem. Okay, we can't even take it to the next level, but we know that this is occiput, this is posterior arch of C1, and so on and so on. Okay? Flexion. Doesn't matter how you have the patient stand, they can be standing looking at that wall or the windows, it doesn't matter. We set up with our 8x10 exposed area, and we're still aiming at the thyroid cartilage, so what do obliques, lateral, obliques, and flexion extension all have in common? We're aiming at the same anatomic spot. Okay? And once you've organized this to the size that you want, less than 8.5 by 11, it stays that way. And it doesn't matter whether it's the largest student in the back of the class, his neck, spine is still in the middle. I can fit him into that space. So everybody in this room except Dorian, okay? I'd have to make that area exposed bigger, but his spine is still in the middle, so I can probably get away with it. Everyone else will fit onto the clipboard size. It's your responsibility to put their spine in the middle, okay?
Mhm.
All right, on this one, I'll just do it the same way he is. You say to them, can you bring your chin in? And if you have to show them, do this. Bring the chin in and down. Always to patient tolerance. So if they can only do this because they've got paraspinal muscle spasm, that's it. After 4 weeks of care, they should be able to go further, right? So it's always to patient tolerance. Extension, click, you set them up. Can you jut your chin out and bring it back as far as you can? A lot of people have different ranges of motion, always to patient tolerance.
I have a really simple question, it's probably stupid.
There's no such thing, right?
Okay, if you put a patient this way against the wall, okay, and the picture's been taken, will the X-ray be reversed? Or will it be essentially this way? Because I'm asking about the oblique shot we have right there. Because
Okay.
technically, if this is what I was asking is, because this looks to me like the left shoulder's against the wall.
I don't know with 100% accuracy unless I know.
Right,
Okay.
okay.
All I can say is when I'm standing here, someone better put the left marker here if they're not.
Okay, but if you, let's say there's no marker there, and,
I don't know whether it's-
Oh, I got you, okay.
We
I
can't
don't know whether it's
assume,
this way, so this would be a left anterior oblique, right?
But when you, the final X-ray, will your, I guess, chin be exactly like that picture, or will be your?
But that's what I'm showing you, look. I'm gonna position exactly how my chin's here, right? Okay? It can't, it's pointing towards that
So
window,
it should
right?
have been left.
This is the issue.
That's why I got confused in my head, and I was contemplating to him, I'm thinking that.
So I'm saying, we can figure it
I
out,
got it.
okay? But the definitive way is to ask somebody, was this against? Now I know they do left anterior obliques. The problem was they chose the wrong mark.
I wasn't sure if there's X-rays that flip the picture, but anyway, I just figured it out. Thank you for clarifying.
But it's not that simple. You can flip the X-ray on the digital systems.
Uh,
Now it gets another layer of challenge, right? But we always follow the convention. Was the chest against the wall? It's anterior, hasn't changed any. And if I'm standing like this, which marker should this have been?
left.
Left.
So this picture was flipped, or we don't know.
We don't know.
Okay, got it.
What we're trying to do is simplify and say, we're gonna follow this standard.
Right.
Mark the side that's closest to the film and decide whether it's anterior or posteriorly performed.
So-
When in doubt, call the office and
Got it.
ask.
Got Got it. So if I get this in my office, I will call the office, be like, hey, was this digitally flipped, or is this the correct
Well, the first
side?
thing I start with is, which side was the patient, which side of the
Got it.
patient was facing? Because you're doing the report, and if you assume this to be correct, you're gonna, it goes domino, 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 it's wrong all the
You'll
way
fall.
through. Yeah.
Yep.
The attorney looks at it and says, I've seen some reports, I'm not sure this is correct. They call in the specialist would be, not me, somebody else like me, and they say, I'm sorry. The way most chiropractic colleges do this is, if the anterior portion is against the chest, this is should have been the left marker. Okay? Dr. Damien, well, it doesn't even get to court, the attorney would say, I can't use that document, it's obviously false. If it slips through his cracks, your cracks and his cracks, the opposing attorney is gonna have a field day, because this is wrong.
So I get this, I'll just, if an X-ray machine, I'll just redo their X-rays, because clearly I didn't take them.
Okay, that's one way to protect yourself. Or you can just digitally erase this,
Okay,
subtract it, and put the correct one on.
got it.
Okay, but your document should say, the marker was incorrect, I put on the appropriate one.
Okay.
So digitally, and that's where we get into trouble, the hackers can go in and change all your right markers to left. Now, all your records are false, are incorrect. That's how the hackers can do this. So the best way, even though we have digital equipment, you know those little markers? That's the best way to do it. And we get this discussion every time, and we argue, and those sets of markers we can get them for $8 down here in Fort Lauderdale.
Okay.
And the chiropractor says, I can't afford that. Well, just a minute, you had a venti latte with macchiato and something on top this morning, and that was $10, and you're telling me you can't afford the markers? I'll buy them for you. Okay?
Got it.
The next thing is, this is factually correct. This is just the way that we can test ourselves. So if you want to have some fun at Christmas, this is Ken. When can you go to the chiropractor's office? Easter, some weekend when you're shadowing, okay? And just ask them, okay, do we take anterior or posterior obliques in this office? You'll be shocked at how few chiropractors take no obliques at all.
Wow.
My question is, do you have patients with radicular arm pain? Of course you do. You need to know the status of the intervertebral foramen. That's the first challenge or thing you'll notice. The next thing you'll notice is, okay, we do anterior obliques. Well, I haven't had these obliques yet. We haven't learned that in chiropractic college. Just ask them, can you tell me on a cervical left anterior oblique view, which IVF do we see? You know it's left. If you get any other answer than left, maybe they graduated a long time ago and forgotten. They don't care, or they don't give up, starts with S and ends with T. Okay? But they say, I treat PIP cases, personal injury protection cases all the time, and motor vehicle accident cases. Well, it's possible that your reports are wrong. Okay? I don't care what they do, I care about what you're going to do individually after you graduate and I'm not around. It's you need to make, some things are more important than others, and that's this. A lot of chiropractic physicians don't tilt their tube. Well, if the IVF is this small, when you don't tilt the tube, it gets this small. We want to see things more clearly, not be encumbered by issues, okay? So there's a reason why we do what we do and why we do it, all right? Some of our colleagues out there in the real world, they don't want to take an AP open mouth view. Well, when your head hits the steering wheel, the level, the vertebral body level that's most often injured is the second cervical vertebrae, and it fractures. Are you telling me you have patients who her head hit the steering wheel? Yes. Should you be suspicious of fracture? Yes. So you're doing one less view because that makes you more certain? When the head hits the steering wheel, make sure you do the AP open mouth well. Now, we have a lateral to help us compare, but if the lateral is not very good, you're defaulting to the AP open mouth. The AP lower cervical isn't going to help you because it's for C3 through 7. Does that make sense?
Yes.
In other words, your good work stands by itself. It also your work sends out a status of your reputation, what you think, okay? Similarly, we don't even have to talk about the converse, right? I don't want you to think about that. I want you to get in the boat and raise the level of the expectation for all of us in the boat. And I don't have to worry about, well, she didn't quite understand what we were teaching her or whatever. If I have to come and testify in court, which I probably will not do because you're my colleague, I'm not gonna throw you under the bus. But if another chiropractic radiologist says, sure, that's what I do for a living, okay, he's gonna testify that the oblique view should be done with tube tilt. Doctor, why did you not tilt the tube on your oblique views?
I'm tilting it now.
Okay.
No, I'm kidding.
Is it possible that maybe you didn't understand how to do oblique views? Yes or
Yeah,
no?
exactly. That's
Okay?
true.
And then it goes, well, if you do this with your x-rays, what do you do with your billing, madam? Okay, is it possible that maybe you'd build one letter that should have looked like a 2, should have been you looked like a 7, but it should have been a 2? Is that possible?
It's possible.
Okay, and then you would just
Investigation.
turn another rock, and turn another rock, okay?
Awful.
And why do we do that? Why does the attorney do that? It happens in every profession, but we're chiropractors, so what do they take? The people that don't document well, okay? The people that take bad x-rays, and you just want to make examples of it. It's not fair, okay, but it happens to the MDs, all right? Where were you trained, who was the instructor, and how did they tell you how to do it? And that's the standard, okay? All right, so that's what IVFs look like. We're gonna show you how to do that, and we'll have no problems if you understood what we were trying to do with the first 3 views, okay? So this is what it looks like. So the space between occiput and C1 reduces when you do flexion. All right, notice the angle of the mandible is, you can tell it's tipped down. On extension, the occiput is going inferiorly at this level, so then we make an evaluation of what's happening at each level based on the changes that we see. We'll show you how to do the analysis, all right? So an example of flexion and an example of extension. This is commonly done when the patient is in a car accident, all right? And most chiropractic physicians say, okay, you're already here, let's do all 7. I did things a little differently. If they didn't have arm pain, I wasn't going to do the obliques. I'll just do the 3 and then flexion and extension. Now, if they have arm pain after the car accident, of course I'm going to do the 7 U's. And the 7 U's is called a Davis, D-A-V-I-S, series. So either 7 views or the Davis series. Those of you that are contemplating staying in South Florida, you're going to have this all the time because we just have a lot of car accidents, okay? And then this is just a positioning. I don't need you to know how to do it. I just need you to realize if they have a big trap muscle like Damon would have, okay? We have to have a special view because we're not going to see your C7 cervical vertebrae, even though you pull your shoulders back. This is a special view designed to see this vertebra body level, and it happens to be called this because this reminded somebody of a swimming position. Now, just because we don't see C7, or the better question is, how can C7 be injured? And the biggest mechanism these days at the gym, the weight behind the neck is too heavy, the barbell drops, and it hits the largest cervical spinous process, which is which one?
C7.
C7. Now, if you didn't get it, 3, 4, 5, 6, I should be able to see 7 on a good flexion view. But if there's injury there and I want to substantiate the injury, the next examination would be this swim lateral. I just need you to know there's an extra view to see the C7 vertebral body specifically. That's it. Okay? There's all kinds of other views we don't need to know about, okay? You're going to do your first project for me, so this is for extra credit. Okay, if somebody wants to go to on their phone, go to this site. Actually, if you all have phones, you can do it right now. It's going to make you download an app, right? Well, just tell me when you're there.
Get off the side. Take it
great, right?
Sounds like the Army. I'm downloading it.
Is it going faster on the computers?
Just-
Here's awful. I have Sprint, that doesn't help either.
All you guys on it, get off.
Yeah.
Oh my gosh, then I have to go to the App Store.
Let me get off of Wi-Fi and see if it helps go faster.
Is this little one with the rib cage, right? Or do you know?
I don't know. Well, I think. Yes.
Okay, sweet. Just wanted to make sure. Oh, yes. Now it's just the Face ID, so you kind of forget your passwords. At least I do.
All the time.
Like,
I had nothing but problems with my Apple ID.
it's,
All you gotta do is do the face.
No, that's fine.
oh my God.
I didn't take screenshots of it, but then you find the anatomy quiz tab. You open the anatomy quiz tab, you find, it says spine quiz. There's 41 questions in the spine quiz, okay? It's not how many you get right. You can go back and click until you get the right answer. It's repetition, okay? Once you've got it downloaded on your device, you can test yourself now and later. I mean, you're not fooling anybody except yourself, okay? I just want you to get used to the technology, all right? And then we just came from a meeting with the head honchos, okay? And they want me to use OneDrive. So by Thursday, I want you to email this to me before we start lab on Thursday at 4 o'clock. It'll take you all maybe 20 minutes, okay? And I will have created a OneDrive folder. Now, people who have Mac devices, you may have some issues, so you're gonna get, I'm gonna set up your folder, and I'm gonna send you a test, a link. And I don't know whether that's gonna work seamlessly, those of you that have Macs, okay? And I'll know by Thursday, because I'll ask you, did you receive the link, and we can mess with it in lab so that it works for you, all right? So we're still gonna use the paper in spite of what Dr. Illis says we should do, but you wanna go to OneDrive. My experience with OneDrive is Mac people, it's a bit of a challenge,
Hassle.
it could be, okay?
I have the OneDrive app on my iPad. I don't know if that makes a difference.
It's not on your iPad,
Yeah,
you're trying to get into the
Reach out.
Kaiser Garden,
Oh.
that's the problem.
The gardens.
Okay, there's a wall around the garden and it only lets certain people in,
It's a victory garden.
okay?
Yeah.
So we'll see what your experience is on Thursday. So if I send you, when I set up your folder, I'm gonna give you a test, a link, and then if you can get in, we're golden. If you're not, we have to try it again or do something else. Okay, but we'll usually do the projects, I'm just trying to pacify some people. Yes, I'm using OneDrive.
So we're supposed to take the quiz and then take a screenshot or
No,
something?
just say, I completed the quiz, and you should all get 100% because it's not graded, it's click until you get the green bullet, right? Okay? But you're supposed to be learning something, so
Got
if you
it.
didn't know where the pedicle was, or if you get more than 10 wrong,
Messed them up.
Go back to anatomy.
go see Dr. Perez.
Prepare for crushing.
Okay, so this is really incorrect. I don't want you to bombard my emails, I want you to upload it to your OneDrive, I will do that before Thursday at lab.
Okay, thank you.
All right. Okay, it's that time, let's break. On the next thing we'll talk